Hi, everyone. And I think we'll have some more people joining in the next minute here. I'm going to give people a little bit of leeway. But just so you all know, as you're coming in, this is being recorded. So that's the most important information. So if you don't want to have your face on camera, it won't be unless you're just speaking. But if you want to speak without your face on camera, then you should take yourself off camera. All right. Let's get started. I'll repeat the message again, just so people are clear. We are recording. This will be posted to the website. So if you don't want your face to show and you plan on speaking, asking a question, you should take yourself off camera. The other important technical information is that we cannot unmute people. So if you do want to speak, you do need to actively unmute yourself. But welcome everyone. This is a joint data-driven justice and stepping up initiative webinar on coordinating a system response to 911 dispatch. We're very excited. I think we have an amazing panel today. If you have any technical issues or questions, feel free to message me or Kia individually on Zoom or send us an email. Hopefully everyone should be smooth sailing. And I'll pass it on to Kia for introductions.
Thanks, Charlotte. I'll just briefly introduce myself. I am Kia Pollard. I am a Justice Program Manager in the County Futures Lab, and I manage the Stepping Up programs as well as the Peer Learning Network for the Safety and Justice Challenge with the MacArthur Foundation. We will go through this thing, hopefully super smoothly. What I'll do first is allow our panelists to get their introductions. I will introduce them, and then we will move forward with the presentations from the panelists at that point. So is everyone, we've got the instructions on mute. Can you change the slide? Muting and unmuting. We went through this briefly. Charlotte covered this, but just very quickly. So you see the instructions here on how to mute and unmute and start and stop your video. Kind of the Zoom basics on accessing the chat box in your bottom field here, and lowering and raising your hand at the point of Q&A. We'll open that up near the end, and we'll actually have you all drop questions in the chat as you see the presentations and as it comes up for you while you're listening to our presenters. So we'll moderate that, and we will be asking the questions that you drop in. But if you'd like to speak, again, as Charlotte mentioned, be mindful about the video recording if you want it on, and just raise your hand and proceed with speaking and unmuting yourself that way. Anything else, Charlotte? Do we need to
add? We also had a question in the chat for the panelists to introduce themselves and locations in the chat, if that was possible. I think as long as that happens in the first few minutes here, that's okay, but I think it's a good idea.
Yeah, and also I see in the chat a good point about folks when they introduce themselves. Feel free to drop in the chat who you are, what jurisdiction you're with, say hello to everybody, and just introduce yourselves as we continue through the presentation today, and feel free to chat with each other too while you're here and make it as interactive as possible. Okay, with that, I'm going to move forward with our limited time here and introduce our panelists. First up, we have Rebecca Neustetter. Rebecca Neustaedter has dedicated her career to advancing equity in criminal justice and healthcare systems. She's focused on reducing justice system contact, disparities, and collateral consequences, as well as enhancing public safety, civic participation, and opportunities to support health and vitality. Rebecca holds several appointments, including trustee of Friends of Island Academy, a nonprofit organization that supports and brings opportunity to youth during and after their time in New York City jails, research advisory board member of the Police Executive Research Forum, and research advisory committee member of the International Association of Chiefs of Police. Rebecca holds a PhD in criminal justice from John Jay College of the Graduate Center, City University of New York, and an MS in Urban Policy Analysis and Management from the Milano Graduate School of the New School University, and a BA in Sociology from Chapman University. Our next esteemed panelist is Laura Euland. Laura has been with the Valley Communications since 1981. She began her career as a 911 dispatcher and promoted to supervisor, operational systems coordinator, and operations manager before being appointed as executive director in 2011. She serves on the Puget Sound Emergency Radio Network Joint Board, the Community Connectivity Consortium Board, and is a member of the Rotary Club of Renton. Laura is a certified public safety executive and registered public safety leader with APCO International. She's also a mother of 2 and a grandmother of 1. She lives in Renton, Washington with her husband. Next panelist is Charlie Verplow. Charlie is the assistant director for the Department of Behavioral Health Services. She received her BA in sociology from Smith College in Northampton, Massachusetts, and her MA and PhD from the University of Iowa in sociology. Charlie oversees the Behavioral Health Initiative for the department, a $20 million reoccurring gross receipts tax used to fund community providers for behavioral health services, not otherwise funded. And last but not least, we have Chiara Jaranilla. Chiara is a crisis call diversion program manager, and Chiara provides general oversight of daily operations and coordination with stakeholder partnerships at Crisis Call Diversion. Chiara joined the Crisis Diversion team in 2019 as a team lead responsible for data and quality review and was appointed program manager in 2020. Chiara has a background in the mental health crisis field with previous experience working in direct care and management, Harris Center's 24-hour crisis line, and the mobile crisis outreach team, as well as experience with working with crisis text line and the Houston Area Women's Center. Really excited to have this panel. As you can see, they are amazingly talented and have a lot of expertise to share. So we will jump right in and pass it to Rebecca Neustaedter for her presentation.
Thanks so much, Kia and Charlotte. It's really a delight to be here with all of you today in this virtual space. Please feel free to shout out if you can't hear me or if you have any issues with my presentation as we go out. But I am gonna try to keep my presentation or remarks really short because I know all of you are eager to hear from the different municipalities that have joined us today. So just starting off, my name is Rebecca Neustaedter. I'm the Executive Director of the Health Lab at the University of Chicago. The Health Lab is one of several sister labs within the urban labs at the University of Chicago.
Rebecca, it seems like we lost your audio. Oh, we may have lost her altogether.
Yeah, I think she dropped off.
Yes, she is lost.
I don't see her.
Okay. All right. We can actually move forward maybe. And so when she comes back, we can have her start her presentation again. But so next we have Laura Euland, who is going to give us a really unique perspective as an executive director of a 911 dispatch center, Valleycom 911. Thank you so much for joining us, Laura. I'm really excited for your presentation.
Thank you, and hopefully I'll have longer staying power than poor Rebecca, but connectivity is what it is. So hello everyone, thank you for allowing me to be a part of this. My name is Laura Euland. I am Executive Director of Valleycom 911. I'm glad to see that there are several other 911 agencies on this webinar. Valleycom is in King County, Washington, which is the Seattle metro area. We are not a part of Seattle or city of Seattle, but they are our neighbors to the north, and we have Tacoma to the south. So we were formed in 1977 when the mayors of 5 cities in South King County got together and said that they realized they could do a better job for their community if they did 911 together, which was relatively unheard of 44 years ago. So they did just that. They formed through an interlocal agreement. They formed Valleycom, which is a public entity, and donated building, equipment, personnel, and started answering 911 calls and dispatching for their police and fire units. I joined in '81, back before we had computers, and wrote everything down on cards and did timestamps. I'm sure some of you can relate to that. But in the 44 years since, we have grown. We have, on the next slide, please, we'll show that we have 25 agencies that we dispatch for. We are a multi-jurisdictional, multi-disciplined 911 center. Fairly large, with 142 employees. We are a standalone PSAP, which means PSAP is Public Safety Answering Point. And standalone means that we are not associated with a city government or a county government. I report to 5 mayors, and I usually say, please pray for me after that. But we do have a governance structure of an administration board, and we have the police chiefs and fire chiefs act as an operations board that help give input and guidance to our policies and procedures. In King County, there are 12 PSAPs, and they're all independent of each other. But what unites these 12 PSAPs is the King County Program Office. And it's the program office that collects the excise tax from the state. And it's the program office that owns the 911 telephone system. They are charged by law to provide 911 to the public in King County. And the law defines 911 as call maker to call taker. So from the public dialing 911, the program office is responsible to route that call to the correct location, to the correct call receiver who says, 911, how can I help you? And that's where the program office jurisdiction stops. The rest of it, dispatching, interrogating, dispatching, and any tools used to do that is owned either by the PSAP themselves or another entity, but not the program office, which is a little complex and adds to the data challenges that I'll speak about later. As a standalone PSAP, Valleycom has our own IT, finance, budget, HR, public records division, training and operations. We own the building. We own part of the radio system that is in King County, and we own the equipment minus the telephone system that's inside our building. We do overlap with the King County Sheriff's Office, since of the 12 PSAPs, there's only 4 that are both police and fire. King County Sheriff dispatches only police, so we dispatch the fire in their area, part of their area. A small portion of our 911 calls come from and through the Sheriff's Office. So we have strong working relationships with the county and with the other PSAPs. So next slide. There are three main systems that we use to process 911 calls, and this is the same regardless of where the 911 center is located throughout the country. There's the telephone system, which, as I mentioned, is owned by King County. CAD, computer-aided dispatch, is the main tool that the call receivers and dispatch use. The information that the call receiver obtains is entered into the CAD system, and then based on the address and the type code that the call receiver assigns to the incident, the system knows where to deliver that incident, which dispatcher in the comm room to deliver that incident, who then dispatches the first responders and then maintains the all of the information flow, requests, monitors the whole situation through the life of the call. When the call is ended, meaning the officer or the firefighter says, "We're done here, I'm clear," we close the call and it is sent down to the appropriate agency's record management system. But the CAD component, any information that is updated into the record management system, once the call is closed and sent down, it does not go back up into the CAD system. So as far as we know, our information stops as soon as the call receiver or the dispatcher closes the incident. And that's an important point because that's a data pain point right there, which I'll talk about in just a few minutes. The PSAP owns the CAD system. They're very expensive. And because there are 12 individual PSAPs in King County, that means there are 12 individual CAD systems, different vendors, different networks, different versions if they do happen to have the same vendor, and they don't talk to each other. There's very little interoperability with the CAD system. There's great interoperability with the telephone system because it is one system. And then there is the radio system, which is owned partly by Valleycom. We're the only PSAP on this ownership of this countywide system. City of Seattle is an owner, King County itself is an owner, and then there's a consortium of cities, 5 other cities, that is the 4th owner. Great interoperability because even though it's 4 or 3 subsystems, they act as one system. So anybody in the county public safety can talk to each other. PSAPs can talk to each other through the radio system. But it's a 25-year-old system. It's an 800 megahertz system that we're currently in the process of replacing. And getting data out of it is extremely difficult, partly because it's an old system, but also because we don't have direct access into it. King County manages it for the owners, and it's just difficult to get information out of it. Those are the negatives on our data. So the next slide is one of my favorite quotes. I am a bit of a data wonk, and I am surrounded by data, but I don't have the information I need to make meaningful decisions. And so that's our challenge right now as a PSAP, is figuring out how to marry all of our different data sets and make meaningful decisions from them. And I will say we're better than we used to be, but we have a long way to go. So in the next slide, I'll talk a little bit about what we're doing to change 911 in relation to alternative responses and just to serve our public better. And there are 3 main initiatives that we're working on. I'm pretty excited about, but this is the future of 911, and it intersects nicely with the future of policing. So our mental health co-responder program, I know there's lots of co-responder programs that are already up and running. King County has and Seattle have co-responder programs, but the South End doesn't really have the resources that we need to serve the public the way they need to be served. Our 600,000 yearly call for service, 80% of that is for police, and the only option we have to send are police officers. So our 9 police agencies got together and said, let's go after a grant, which they were awarded to stand up this co-responder program that would serve the South End. 6 months of funding, 1 team, which will be 1 mental health provider and 2 navigators to follow up, which is a drop in the bucket for the need, but it is a good start. And Valleycom is in the conversations to develop this program because we're the commonality of all 9 of these cities. We're the hub. We don't see a change in our call process at this point because the model is that an officer has to have eyes on the scene, be at the scene before they request this team. But eventually, it's reasonable that it will be the call taker that decides, does this call for help warrant a police officer response, or is there a mental health response that would be better suited? So excited that we're finally getting to this point. Long way to go, but we've come a long way already. The next is the 988 National Suicide Hotline. We, Valleycom, and several other PSAPs are working with our local legislators to introduce a bill into the state legislature to stand up this hotline. We all know nationwide that we've got to get this up by July of 2022. And we're working with them to let them know that this will be a location, it'll have to be a location-based call routing structure. And that already exists with the 911 system. We're not advocating that 911 call receivers staff this suicide hotline. We aren't trained for that, not certified for that. But the technology that routes a 911 call to the correct PSAP could also route the same 988 call to the correct call center. And we're helping them. We get those calls today when we don't have, as I said, the resources to send. So they're recognizing that we have input to this, standing this up. And again, pretty exciting. We expect to work closely with 988 once it's up and running because we'll be transferring calls to them. The third topic, racial equity and 911. So after the events of George Floyd's death and subsequent calls for justice and reform in police, we recognized here that the 911 system, the 911 call taker, is the gateway to public safety and calls for help. And there is potentially inherent bias that we may not even be aware of that contributes to the reasons that we have demands for police reform. It is the call receiver who paints the picture, sets the tone in the mind of the first responder. And so there's a responsibility to make sure that we are doing everything we can to make sure it is bias-free. I worked with a local consultant that helped us with our strategic plan and said, what can you do for us to give us awareness and training on the importance of racial equity in 911? And they developed a training. Rebecca Newstetter was part of that, and it was eye-opening. We invited our police agencies to attend, and we have a new awareness, a new call to look at our procedures and our policies and ensure that we are not putting any barriers in any hiring practices, and also that we're not imparting any bias in how we deliver our calls for service and our service to the public and to the police officers. So my last slide in closing is we have to change. We have to adapt to the needs of today. That's not a strong suit for 911. We like to do what we've always done because it's comfortable, but we are working to change our delivery, our mindset. And another favorite quote of mine is, what got us here isn't going to get us there. We have to change. So thank you for your attention, and I'll pass it back to Chiara.
Thank you so much, Laura. That was wonderful. I'm really, really excited to have your perspective here today. We are going to pass it back to Rebecca, who is experiencing the absolute joys of working from home, I think, right now. But she's back. And just to reintroduce her, she is the executive director of the Health Lab at University of Chicago. Thanks.
Thanks, Charlotte. Thanks, everybody, for their patience. I guess it has to happen to one of us in order for this webinar to be truly COVID compliant. But apologies again. I'm delighted to be here with you all. My name is Rebecca Newstead. I'm the Executive Director of the Health Lab at the University of Chicago. The Health Lab is one of several sister labs that sits within the Public Policy School, the Harris School at the University of Chicago. And our objective is really to work in partnership with cities, and I'll discuss that in just a moment. But today my presentation is to really describe a little bit about understanding law enforcement response, and I'll be brief. I know you want to hear from the municipalities, and Laura's done a terrific job of helping lay that groundwork for us. Next slide, please. The way that the urban labs work is that we essentially identify promising solutions to urban challenges. We work with civic leaders in order to test those solutions, policies, and programs. And then we try to take to scale what's deemed effective and cost efficient. The Health Lab, we work directly at the intersection of health and safety and justice. And the 911 system really is the linchpin between all of those systems. And the 911 system being the gateway really at writ large between the criminal justice and social services and the needs that communities have. We're doing a number of different projects currently in the Health Lab that focus on 911, some predictive analytics work, and some interventions-based work with people who are suffering from mental health disorders and other intellectual and developmental disabilities. I'll describe a little bit today about some work that brought me here, as well as some work that we're doing to advance those other efforts. Next slide, please. So as I think we all know, the 911 calls for service process is a little bit of a puzzle, and we're trying to take disparate needs and services and to connect the right people to the right responders at the right times. And that doesn't always work as perfectly as we hope that it would. And that's primarily because it's not a linear process by which the 911 call processing system works. Next slide, please. This is a very sort of rudimentary version of how you could visualize the 911 call processing system. It'll vary by jurisdiction and certainly by call, but essentially what happens is an individual in the community or a business member dials 911. They relay information to a 911 call taker who then essentially determines if the call requires police, fire, or medical response. And essentially what that means is there a fire, is there a medical emergency? And if it doesn't fit into either of those categories, then it defaults to police response. The information is gathered, and then the call taker, call receiver is responsible for assessing what the priority level of that call is and the urgency by which responders should be sent out to the field. If it's a super urgent call, like shots fired, some jurisdictions will have an automated emergency dispatch system, and that'll go directly to the field. Otherwise, what usually happens is that call taker enters information into a computer-aided dispatch system or a CAD system, and the dispatcher then further assesses the need and then deploys the right responder, fire, to the right location. And there are all kinds of other sort of complicated details that happen there. But what can also happen is that multiple callers may be calling the 911 public safety answering point PSAP at the same time, or that the original caller may call back. So you can see sort of a circular process. But when the officer does respond, they have a number of different options available to them in order to dispose of the call. They can write a report, they can provide instructions or assistance, they can make an arrest, they can call in other resources, or they can, what often happens, really like do nothing. Next slide, please. What we know from the 911 call taking process is that it is a little bit of a game of telephone. Many of us know this game from our childhoods or playing with our own families. And you start out with one piece of information and going through these different actors that are working simultaneously, the information and the needs can be altered. Next slide, please. And this has really life or death consequences in many instances. It's not as though you are taking a message that says needs to bees and it's really innocuous in that way. There are lots of cases in which information is not transferred into the CAD systems in a way that is entirely accurate or depicts the reality of the circumstances. For example, 12-year-old Tamir Rice, who was playing with a toy gun in a nearby park playground to his home, and a passerby called 911 and described the situation as probably a child and probably playing with a fake gun. However, that information was not relayed in that manner into the CAD system, and instead officers were sent to a playground for a gun call, which is a very sort of different level of response than what this may have warranted. We'll never know the true counter effect if that information had been transferred properly, but I'd really like to think that the officers may have slowed things down, been more cautious, and been expecting to see a child possibly playing with a toy rather than a gun call at a park. Next slide. We really need to examine the 911 system though, because as Laura mentioned, and as I've mentioned previously, it truly is the gateway to the criminal justice system and the social service systems. There are not sort of national reliable figures, but what we do know is that at least 240 million calls come to 911 every single year, and that it represents one of the broadest sort of civic engagement efforts that we have in this country. Yet we have huge gaps of information in terms of why people are calling, what their underlying needs are, and how those are being matched. Next slide. So when we want to understand police response, we really do need to look at 911 dispatch. And 911 is a relatively new enterprise. We did not receive our first 911 call in this country until 1968 in Alabama. And it wasn't until 1999 that Congress formally established 911 as the nation's universal calling number. So despite the sort of nature of feeling like, you know, 911 is this young and has been very research and knowledge that can be brought to bear. Next slide, please. So I'll discuss briefly some research that I've done previously where we wanted to better understand 911 call processing. And there are two parts of this analysis that I'll highlight briefly now. The first was that research assistants gathered audio records of 911 calls from 2 different jurisdictions. And we tried to, using the protocols and the guides that those jurisdictions employed for coding the calls, we tried to sort of blindly apply what we thought the codes should be in the cases of these calls. And what you'll see here is that we very rarely could actually match the calls. In most instances, we could match the priority level, but by and large, we were not able to match the type of call. And so what this leads us to believe is that there likely isn't a lot of reliability between how different call takers and how jurisdictions are coding calls, and that this like further limits people's ability to respond to them properly. Next slide, please. And so in looking at the data now more from an analytic descriptive perspective, and I won't go into this too deeply, but to say that even of the smallest of agencies in the country, that they most often are receiving hundreds of thousands of 911 calls every single year, that the vast majority of these calls are non-emergency calls, that they are most frequently going to be calls like welfare checks, disturbance calls, or even 911 calls. That even though we often think about 911 calls as happening in the middle of the night and police being the only folks on duty to respond to those calls, that in fact, many of these calls are actually occurring sort of late in the afternoon and into the early evening. Next slide, please. What we also know is that most police departments, the vast majority of the police officers in those departments are spending their time just reactively responding to 911 calls. Next slide. And that, again, when we're talking here specifically about alternative responses, if we think very concretely about behavioral health kinds of calls, missing persons kinds of calls, calls that are often highlighted as eligible for diversion and deflection, that these tend to comprise a very small proportion of the calls, less than 2% in one agency that we looked at. If you can go to the next slide, please. And just over 5% in another agency. So I hope that that provides a bit of the landscape for what we're talking about in terms of the importance of 911 call taking, how it serves as the gateway, and opportunities to really dig in more deeply. Quickly, I'll just touch on some of the things that my colleagues and I are involved in terms of advancing this work beyond the predictive analytics and interventions-based work. Next slide, please. We have recently launched an initiative called Transform 911, in which we're working to centralize and evaluate the evidence base surrounding the 911 call system in order to identify limitations and opportunities, as well as to spark creativity and innovation into alternative approaches. And toward the end of developing explicit policy recommendations that can achieve change at the local and national levels. There are 3 activities that we are pursuing in order to accomplish this objective. We are advancing a national dialogue in order to really develop the people's history of 911, and that relates a little bit to what Laura was describing in terms of understanding race equity in 911. We're working to develop a community of practice around 911 to facilitate a national virtual roundtable, as well as to centralize knowledge and resources as it relates to 911 and to build blueprints for change. So next slide, please. So I'd ask you to please take down my contact information, and if you are interested in any of the work that we're doing or you have any questions, to please feel free to contact me and my colleagues, and we look forward to seeing this field grow in the future. I'll also put my email address in the chat bar. Thanks so much.
Thank you, Rebecca. We will move right along and take this opportunity to actually remind you to drop your questions in the chat, and we will moderate that shortly at the end of all the presentations. And we'll move through to Charlie, who is the Assistant Director for the Department of Behavioral Health Services in Bernalillo County, for her presentation.
Great, thank you so much, Kia, and thank you guys for inviting me to speak today. Again, my name is Charlie Verplow, and I am the Assistant Director for the Department of Behavioral Health Services. And one thing I wanted to mention up front is that police are often called to respond to mental health emergencies. However, this solo police response is really changing in cities like ours, and as we are beginning to consider implementing alternative response models, which is what I'm going to talk about today. Police have often been sent out to respond to mental health calls and substance use emergencies really for decades now, and in part because I think there's a public perception that these calls are dangerous. although this really hasn't been bared out in the literature and research on this topic. So today I'm going to talk a little bit about our model here in Bernalillo County in New Mexico. And this includes a law enforcement response with a behavioral health clinician and a non-law enforcement response with a paramedic and a behavioral health clinician. These programs, they respond to non-criminal activity or low acuity behavioral health calls that come into the 911 dispatch system. And these teams try to de-escalate and provide crisis assistance to cases where a police response solo might not be as necessary. So again, this slide basically covers the things I'm going to talk about today, a little bit about our background of our funding for this program, what our mobile crisis teams are and our non-law teams are, a few programs in our crisis continuum and some of the challenges we face. Next slide. So in Bernalillo County, we've been working for many years to address and mitigate gaps in the behavioral health continuum. To give you a little bit of background about where the funding comes from the county side, in 2014, the County Commission took a ballot question to the voters and asked them if they would be willing to tax themselves to pay for some behavioral health services in our county that were not otherwise funded. And with an overwhelming support from taxpayers, this tax was passed in 2015, and it generates about $20 million annually. So part of that money goes to our mobile crisis teams along with some funding from our city. Next slide. So our mobile crisis teams are a collaboration between our county and the city, the Albuquerque Police Department and the Bernalillo County Sheriff's Office and our Bernalillo County Fire Department. And again, they respond to individuals experiencing nonviolent behavioral health crisis calls that necessitated a 911 response. So we have 6 teams on the Albuquerque Police Department side and 2 teams on the Bernalillo County Sheriff's side. And each of those teams consist of a crisis intervention unit deputy paired with a master's level behavioral health clinician. We also have 2 non-law mobile crisis teams that will come through Bernalillo County Fire Department. Next slide. A little bit about our non-law teams. Our non-law teams are comprised of a behavioral health clinician and a paramedic certified in enhanced crisis intervention training. In the case of the non-law teams, the scene needs to be cleared by a team of officers. And if it is determined to be appropriate, then there will be an on-scene request through the 911 dispatch to send out a non-law team. Next slide. I wanted to talk to you briefly about our program requirements and our target population. So the mobile crisis teams respond to individuals, again, that are experiencing a behavioral health crisis, and that includes children, adolescents, and adults. And our emergency communications dispatch sends appropriate calls to the MCT teams or the non-law teams. Sometimes we get questions about how that dispatch process works, so I wanted to talk briefly about how that works. Our mobile crisis teams referrals are initiated through 2 main avenues. So a direct call could come through that 911 dispatch, or a call could come from an officer who's on scene. They're experiencing a situation in which they've determined that an individual in question is experiencing a mental health related crisis or a substance use need, and that would be appropriate for a mobile crisis team. A call comes into that 911 dispatch system, and that person asks, this is 911, what's your emergency? And also what's your address? And then whatever that calling party states, that points the dispatcher to a card in their emergency medical dispatch protocol. So it's a big booklet, basically leads them to a set of questions that they can go through. So for example, if a caller called in and said, my son is talking to someone who isn't there and he seems to be escalating, I need some support, then that would cue the dispatcher to click to that behavioral health tab and ask down a set of questions that would determine the best protocol to take. If they determined that it was a behavioral health call that was nonviolent, there was an immediate threat, they would determine that that would be a mobile crisis team call. One thing that's really important to note is that not every mental health call or substance use call is appropriate for the mobile crisis team. So if it's low acuity, they could be sent to our New Mexico Crisis and Access line that I'll talk about in just a second. But if it's a high acuity, it might not be appropriate for a mobile crisis team. So if someone was barricaded in a building and had a firearm and suggesting that they might hurt individuals, then that would really be better for a SWAT response rather than a mobile crisis team. So if that dispatcher determines that it's an appropriate call for that mobile crisis team, they can log into that system and find one that's available and dispatch them to the call. I want to note that we need to also dispatch a field unit along with that mobile crisis team. And part of that dual response is because we have SOPs both on our Albuquerque side and our Bernalillo County side that require that an officer not go to any call alone. So both of those units would show up, they would clear the scene, they would communicate to dispatch that it was safe, and then they would communicate to the clinician that they could go ahead and work with that client. At every step along the way, there's communication between the field units and dispatch, and only when they've cleared that scene can that field unit go back into service and the MCT team would stay on the call. Next slide. I did want to briefly talk about our New Mexico crisis and access line. So we have a statewide mental health crisis line for anyone who resides in New Mexico. It's a centralized single telephone number answered by professional counselors. So they answer it 24 hours a day, 7 days a week, 365 days a year. And those counselors will contact 911 as needed, but they're really trained in assessing a crisis and responding with sort of that least restrictive alternative. In the implementation of our mobile crisis teams, we determined that if a call came into that 911 system and it was of a lower acuity, they could patch them right into that New Mexico crisis and access line where they could immediately begin work with that master's level behavioral health clinician. However, if it did warrant a mobile crisis team, they could still link them into that master's level behavioral health clinician where they could talk with them while that MCT was en route to respond. Next slide. I did want to briefly cover, sorry, next slide, I think I'm a slide ahead of you. I wanted to talk a little bit about the data briefly. So we look at call for service data to provide insight into how mobile crisis teams are deployed. Table 1 shows you the progression of events from dispatch to the on-scene response from March 2018 to March 2020. And table 2 really talks about some of our common types of calls for service for mobile crisis teams. So you'll see that suicide-related and behavioral health calls take about 46% of those calls for service. Mobile crisis dispatch calls to check on the status of a person. So welfare check, request for contact, suspicious person, that would take up about 26% of those calls for service. And then approximately about 75 different types of call types take up that other category. So that's 27% of those remaining calls for service. And those might include something like a missing person or a traffic stop or a family dispute. Next slide. I did want to briefly talk about some of our other programs, and I won't go into detail. We found that people engage in the crisis system from multiple locations. So we need these crisis services in multiple locations, along with other types of preventative services. So we have a resource reentry center that is a first stop for individuals to get connected to services once they release from jail. We also have a LEAD program. So that's a public safety program that offers officers discretionary authority to divert individuals that might be suspected of a low-level crime or nonviolent crime that is driven by an unmet behavioral health need and be able to connect them to services instead of arrest. We have some community engagement teams that are peer-led, peer-facing teams that have also some clinical supervisors and opportunities for prescribing capacity, but they really meet individuals where they are in the community and are a good referral source from our mobile crisis teams. We also have a crisis stabilization unit that is a good referral source from our mobile crisis teams, and they are a specialized treatment facility designed for individuals in the midst of a crisis, but aren't suicidal or homicidal, sort of meeting that criteria for an inpatient stay. Next slide. So I did want to briefly cover some challenges that we've faced in case there are other jurisdictions interested in implementing programs like this. One is in our non-law teams, there has been concern about volatility of behavioral health calls and safety of our non-law teams, and that's expressed by law enforcement and our fire department as well. And so as a pilot, we've created an opportunity for those calls to be cleared by an officer team prior to calling out those non-law teams. But we hope as our experience grows that we can learn what calls that we can send them directly to from the 911 dispatch. I wanted to mention we have some challenges, as mentioned earlier, about connection between our city and county dispatch systems. Happy to answer questions on that. And then I did want to briefly talk about maintenance of our behavioral health workforce. So New Mexico is one of the poorest states in the country. We're also one of the highest rates of overdose and suicide in the nation. So because of that, we have a really difficult time maintaining a good, solid behavioral health workforce. We have issues related to licensure and non-competitive pay, services to people people who are on Medicaid, things like that. So to be able to maintain that workforce for such a difficult, high-risk job is something that we're challenged by and continue to navigate over time. A couple of next steps, we want to expand our teams. Obviously, we want to expand our opportunities for peers to engage with individuals. And I think that's where I'll leave it. And if there are questions at the end, happy to answer and talk about any programs that we have. I've left my information on the next slide. So if you want to contact me after the presentation, happy to talk about our programs as well.
Thank you, Charlie. That's fantastic. You did such a great job getting all of that information in one presentation. I'm continuously amazed by Bernalillo and our peer learning network. So last but not least, we have Chiara Jaranilla. She is the Crisis Call Diversion Program Manager for the Crisis Call Diversion team in Harris County. And I will pass it on to her for our final presentation.
Hi, everybody. Thank you so much, Kia and Charlotte. I'm really honored to be here. Like Kia said, I am the program manager for Crisis Call Diversion, and I'm excited to talk to you all about what we do on a daily basis. Next slide, please. So Crisis Call Diversion, or CCD, is a partnership program between the Harris Center for Mental Health and IDD, which is the local mental health authority in Harris County, the Houston Police Department, and the Houston Fire Department, as well as the City of Houston. The program started with HPD in 2016, and then we brought on HFD as a partner in 2017. Next slide. So our mission is to assist first responders and persons in crisis by providing empathy, connection, de-escalation, and linkage to the right size care. CCD is a small team. We have 5 crisis phone counselors and 1 team leader, 1 program manager. And we are co-located directly in the Houston Emergency Center. We're seated right in the middle of the dispatchers area. And a huge benefit of that is having real-time access to the 911 calls as they're dropping in CAD, in the computer-aided dispatch system. Next slide, please. So this is a general call flow for CCD calls. CCD integrated itself into the HEC Center's existing emergency response system. So at any point within the 911 dispatch system, we can receive a referral. So whenever the caller picks up the phone and dials 911 and they speak to the 911 call taker, and the call taker triages for police, fire, or a combined response, as long as the call involves a mental health concern and meets their requirements for a code 2 and a patrol code, they can be connected directly to a CCD call counselor. And the caller is just transferred directly and we begin our assessment from there. If the caller requests HFD, the caller's connected to a HFD call taker, and at that point, the HFD call taker will also triage for a medical emergency in addition to the mental health component. If there's no medical emergency that's being reported, and I'll talk about the triage questions in just a minute, if there's no medical emergency that's endorsed in the call, they can be directly transferred to a CCD phone counselor. If at either of those points, there's no direct transfer that's made to CCD, and the call slip is dropped in CAD and it disseminates to its, the appropriate unit that'll respond to it, whether it's patrol or police desk unit or the teleserve unit, a direct request can be still be sent to the crisis phone counselor to look at a slip. Hey, look at call slip 1234. Looks like it might be, mental health related. Can you call back? And if neither of those things happen, like I said, we are directly in the middle of dispatch and we have real-time access to CAD. So our counselors are pulling and cherry picking mental health related codes off of the call queue, examining the call slips and initiating direct contact with the 911 caller. Upon making contact with the caller, the counselor will complete a mental health risk assessment and will attempt to de-escalate, complete a safety plan. And if it's appropriate in terms of the risk level that's endorsed on the call, we'll try to refer out to either the mobile crisis outreach team, to our 24-hour psychiatric emergency room, or to an outpatient service if that's what is the appropriate referral. After we finish our initial mental health risk assessment and we hang up the phone with the caller, we'll turn around and send a message to the dispatcher relaying just the pertinent risk information that occurred on the call. There's limited info sharing here because of HIPAA, So we might spend, 30, 45 minutes on the phone doing an assessment with a caller, but we're turning around and saying, caller reports, suicidal ideation with a plan to OD. We were able to get him to put the pills, in the bathroom, what have you, whatever the call outcome was. And then the dispatcher will use that information to determine if if emergency is appropriate to be diverted, or if it's appropriate to dispatch emergency response. We don't make the final call on whether or not a call receives emergency response. We clear the mental health component of the call. After the dispatcher decides to divert or dispatch police, the counselor continues to monitor the call in computer-aided dispatch system, and they'll complete follow-up activities. So making sure that somebody made it to the hospital if we diverted the call, or even calling somebody back maybe 3 to 5 days later after they've been transported to a medical hospital, just to make sure that they have the mental health follow-up resources that they'll need on that tail end. Next slide, please. Like I said earlier, the referrals to CCD can be made either by direct call transfer, a callback request, or a self-initiated callback. These are the units that are housed within the Houston Emergency Center. These are all the units we work with in the call center floor. We have the 911 call takers, the HFD call takers and their captains, HPD dispatchers, watch command, which is, the dispatch supervisors. We have the police desk unit, teleserve, and we also receive referrals. This happens rare, but on the tail end from patrol. If there's a patrol unit that is aware of our service or would like us to complete a callback after they've responded to a call and realize there's no police matter that they can attend to, they can request the dispatcher to have us call back on a closed call slip, and then we can try to assist the caller from that end as well. Next slide, please. So these are the questions that the 911 call taker uses and the HFD call taker uses to triage. So the 911 call taker, as long as it meets the code requirements for code 2 and up, they'll ask these questions to triage for a mental health concern. And on the HFD call taker side, these are the questions that they'll ask to make sure that there's no medical emergency ongoing before transferring the call to CCD. Next slide, please. So our training is provided in-house. It's a mixture of classroom training and practical training. These are all the areas that we review. For time purposes, I won't go through bullet point by bullet point, but we do hire qualified mental health professionals who are bachelor level crisis phone counselors. So there is a bit of foundational or classroom training that we like to go through with them. Next slide, please. On the practical training, we have our counselors sit in doing shadowing shifts or ride-alongs with our Harris Center partners that we will commonly refer to, and with our HPD, HFD, and City of Houston partners that are on the call center floor. We do also complete an HPD ride-along with patrol, and I think that really helps our counselors conceptualize what happens so that the response portion of the call, they see it coming in real time in CAD, then they can piece together what happens after that call, after a unit is dispatched. All in all, training takes about 2 to 3 months. And the important piece I wanted to mention here is that our employees are CJIS cleared. We have to go through CJIS clearance on a yearly basis. So with training, that can impact when a counselor can move on to the practical section of training. Next slide, please. So we are not currently funded as a non-essential, we are currently funded as a non-essential program. So this means we do close for any agency holidays, staff trainings, disasters, but we are open 6 a.m. to 10 p.m. all 7 days of the week. 24-hour coverage is something that's in our sights in the future. We'll hopefully be able to expand once we have funding and all that kind of good stuff. And like I said, we are a very small team. We have 5 crisis phone counselors, 1 team lead, and a program manager. Our targets is to provide an assessment for 400 to 500 911 calls for service per month, and to divert a total of 200 to 300 911 calls for service between HFD and HPD. Next slide, please. Oh no, I'm not sure if there we go. I think you might have to click all the way through to make it all pop up. Okay, so for the purpose of time, I'm not going to go through all of this, but some data points that I'm very proud of with my team is that since we hit the floor in 2016, we've diverted almost 6,200 911 calls for service completely away from law enforcement. And since HFD became our partner in 2017, we've been able to divert almost over 2,200 HFD calls for service completely away from HFD response. Next slide, please. So a couple historical challenges at the inception of the program is getting our counselors on the floor, getting approval for co-location at the Houston Emergency Center. At this point in the way that we're structured, there's very little that CCD can do if we don't have access to CAD. And so getting our counselors in the middle of the call center was a challenge, but it has been a huge benefit in our daily operations. Additionally, we are not telecommunicators. We are civilian crisis phone counselors. So navigating TCOL policies has also been a challenge, and we've been able to work around that by how we communicate with the dispatchers and how the dispatchers use that information to either advise the responding officer or close the call slip. And some ongoing challenges I mentioned earlier, the CJIS renewals. As with any partnership, there's portions of the administrative process that you kind of have to go through. And CJIS is something that we do renew on a yearly basis. And a bit of an identity crisis because we are a law enforcement and mental health partnership. So organizationally, we belong under the mental health division, but we're physically located in the 911 dispatch center. So we're under the emergency communications division. And I think this makes our administrative processes just very unique. Next slide, please. Some information about our original funding and our current funding. And I'll go ahead and skip over to the next slide where my information is. If you guys have any follow-up questions, feel free to reach out to me. I'm happy to talk.
Thank you so much, Chiara. That was amazing. And thank you to all of our panelists. That was really, really informative. So we're going to move on to our Q&A. And we're going to take some questions from the chat to begin with here. The first question that we got was, do any jurisdictions currently have an alternative to 911 emergency line that utilizes mental health clinician staffing for the dispatch and response? And I'm going to add an additional question, which if folks aren't aware of any, what they think of it. If alternative line sounds like something that they would want, how that would function. And that's for anyone on the panel. All right, I'm going to call on people then. Laura, do you think that having an alternative line would be something that would be really helpful as someone who's running a dispatch center, or does that seem like something that might complicate things, or do you see a way where we could sort of weave both of those things into one?
I don't know of one. We don't have one in the area to answer the first part of the question. But secondly, yes, it would be incredibly helpful. It would be much more efficient. I can foresee, just like at Houston, our call receiver would stay on the phone with the mental health professional as much as possible to ascertain what the level of danger would be, but it would be absolutely beneficial. I don't know of anyone across the country that's doing that. I'm sure there are, but I'm just not aware of them.
And Laura, I'm sorry, I'm picking on you. I'm going to follow up with, so would that operate sort of like a 311 system? And do you all deal with 311 calls? I assume that you don't. But is there any interplay?
No, we don't have 311 in King County. It's so dependent upon the circumstances. I see the value in having a resource of someone who is trained to take that kind of call. I wish we did have that. But then the need to have a police response is often to clear the scene or to make, if someone's threatening suicide with a gun, the mental health professional's not going to want to go to that, or probably have the skill set to handle it all by themselves. So I think there has to be interaction with a trained law enforcement call taker, but we just need to be a part. As that gets developed, we need to be a part of that conversation and developing it to make sure that all goals are met.
And I'll just add to that. I mean, I think that ultimately we want a system in which there's no wrong entry point, and that people have lots of different ways in which they can access the services that they need. I do want to just like underline, however, that 911 PSAP operations are already really under-resourced and not very well defined or understood. And so I think, like, to me, there's a big sort of cautionary note in developing alternative lines without really investing and making sure that the ones that we have are already working at their highest level of functionality and that they're getting the services to the people that need them. There are ways in which the responder is deployed, but that requires that there are other responders beyond police, fire, and EMS. And just, one other sort of point on that is that, there are lots of jurisdictions that have introduced 311 lines, 211 lines with the hope that it would reduce 911 call volume. And in the little bit of research that does exist on that, I have not seen that to actually play out in reality. And that what ends up happening is that a lot of the additional calls end up getting ran. And so ultimately, I think it's like understanding who can respond to these underlying needs and reducing the burden on people who are in crisis, trying to determine which number they should call for whatever their problem is.
I think one thing I'd also add into the conversation is that our New Mexico Crisis and Access Line really functions that way to some extent. So rather than sort of doubling our costs and creating a further burden on that 911 system, this system was already being paid for through the state, so we could leverage that funding and make sure that that opportunity was there for master's level behavioral health clinicians to be able to engage individuals with those needs, and sort of communicating that partnership between NMCal and our 911 line was able to sort of get at what you're asking for without inserting it right into the 911 system itself.
Great, thank you all. I think we have a question that's going kind of right back to Charlie. Although if anyone else has anything to add on any of these, you should feel free to jump in. So there was an ask for detail on the set of questions that are asked by dispatch on the behavioral health card to screen whether a non-law response is appropriate.
Oh, sure. And so if they'd like to maybe send their information directly into the chat, I can refer some of our protocols over and be happy to share that.
Great, we can connect you all. I'll make a note of that. Okay, so we have another question. Are there issues of recruitment of behavioral health providers willing to respond to 911 calls without law enforcement presence? That's something anyone has seen or dealt with?
So is the question, Charlotte, about 911 dispatchers, or is it about behavioral health clinicians responding in the field?
I believe clinicians.
Okay, sure. Yes. And I think I did mention that particularly for our program, that there has been some concern about safety without a law enforcement officer. And so in our pilot, we've decided to make sure that those calls are cleared by an officer team first prior to the team going out. But like I said, as our experience grows, I'm hopeful that we'll be able to identify exactly which calls are low acuity enough that that response would be appropriate for a non-law team without police response. But I think that's where you start to bring up challenges when you bring in non-law teams, and our jurisdiction is working on that like many other jurisdictions. And I do believe that it speaks to that stigma related to envisioning behavioral health calls as always dangerous and always violent. And so challenging some of that with some of the existing literature and research, I think, is also important.
Great, thank you. And this was directed at Charlie, but I think once again, this might be something that other folks would be able to answer or have an opinion on. The question was asking you to talk a little bit more about how logistically they go about having clinicians talking to people on the phone while you have police and EMS being dispatched.
Sure, and it's pretty straightforward in our jurisdiction, and then I'll turn it to the panel. But basically, it's that New Mexico crisis and access line. They already have a system where they can patch individuals into that clinician to speak with them. So they do that, and then they say, we're also sending a response. They're on their way. Please communicate with this clinician as we respond. And so that's how that works. They're talking on the phone, and then when that mobile crisis team responds, then that person can get off the phone and engage with the clinician in real time.
I'll jump in here as well, because this is the exact model that CCD uses. We don't dispatch or arrive ourselves or document in any way on the patrol call slip. So whether the referral makes it to us because the caller is directly transferred after they initially spoke with the call taker, or we're doing a reach out call to make contact with them, the call slip waits on the call queue for police response. So there's never at any point that CCD's mental health risk assessment postpones the ability of law enforcement to respond to the call.
Great, thank you. So we had a question about metrics and evaluation for pilot programs here. So if we could have the counties talk a little bit about metrics and evaluation, and I guess basically, like, do you have them? Have they been difficult? Is that something that has really been able to bolster you moving forward in your efforts?
So who's that question for again, Charlotte?
I think that's for any of the county folks. But also, actually, I think it would be helpful if, especially if Rebecca knows of any particular specific metrics or evaluations of pilot programs. I think folks are trying to sell this to people in their counties, and it's really helpful to have examples and be able to give some numbers to people.
I think I could speak a little bit to that and again, turn it to the panel, but we have an evaluation team called the Institute for Social Research, and they're contracted for quite a bit of money annually to do evaluations on all of our behavioral health initiative, mobile crisis teams included. And so they do a process evaluation and then an outcome evaluation, and they work with providers. They have an IRB. They work with providers to identify basically several different pieces of metrics that they want to include with those from those providers. And then they do staff and interviews and administrative interviews and things like that. So be happy to share. I'm sort of following people in the chat here, but share offline about some of the details and the metrics that we look at in our evaluation process.
I'll just add, again, as much as we don't know in terms of the operations and how many 911 calls are coming in nationwide and for what and how they're disposed of, there's even less information available in terms of outcomes, the sort of alternative space. And I think Laura may be really actually well positioned to discuss this. Her and her team have, a pretty robust set of performance performance outcomes that they adhere to. But just to kind of put even a point on the fact that there are, two sort of national associations that try to define standards when it comes to call taking, but yet none of those standards are adhered to, and we don't really know who incorporates which of them. So APCO and NINA have, sort of recommendations about how you should structure calls and how you might follow up on them. But in most places, that's not actually happening. And I think it's also a bit complicated because of the sort of interagency and multidisciplinary nature of call taking, and that the sort of final outcome isn't necessarily going to be owned by the agency that's deploying the resource. And so there's, kind of real challenging needs around data sharing and integration in order to actually fully understand the outcomes of these responses.
And that was my point that I didn't quite bring home, that the CAD information stops when we close the call. The record is then sent to the agencies. So if what we dispatched was a disorderly subject, and the officer gets there and finds out it was actually a mental health crisis situation, unless there is express intent to change the type code, it goes down in the annals as a disorderly subject. And there's no connection to the mental health crisis. So we can't get good data on what actually happens, often because there's another call coming in and then the officer goes to another call. And so there's really no space to do that. The 911 professional is, Rebecca mentioned APCO and NINA. 911 professional, there is no certification required to do this job. There's no minimum training to do this job. And there is no, the classification, there's a lack of recognition on the importance of this job nationwide. And federally, a 911 professional is classified as clerical. And so getting every sheriff and police chief to put the emphasis on training and resources causes us to be perpetually understaffed as an industry and frankly untrained in certain respects. In Washington State, the PSAPs voluntarily meet the recommended training levels that APCO recommends, but it's not required. And so there definitely is a recognition issue as well.
Awesome. So I noticed we are at time, and I know there was one more question for Rebecca. We will collect that, as well as all the emails that were shared for Charlie and the follow-up on those protocols, and we'll connect and make sure you all get that. But we want to be mindful of the time and close to time. So this is a thank you to all of you who have attended this webinar, for your participation. And we all hope that you got a lot of insight from our wonderful panelists. We want to thank all of them as well for their time and all the information that they shared with us today. If you have follow-up questions, feel free to send them through to either Charlotte and I, and we will direct them to the right person. We will also make sure that the recording and the slide deck are available on the same webpage as the event link. So when you register, you'll see that page, and there you'll find the slides as well as the recording. So thank you all. Have a great rest of your day, and remember to follow up if you have any other questions for us. Take care.